Thank you very much. Thank you for tuning in, everybody. I appreciate it as always. Hopefully, over the last month since our last webinar, you have been using your diaries to record your diet, your exercise, your stress management techniques, and hopefully that's helping you shed some light on what areas can be improved and what areas you're doing great on. So before we do get started, I want to just make one announcement. This is from the CDC, the Center for Disease Control. They are looking for volunteers, and I'm just going to read very quickly. If you are a former smoker who has been diagnosed with chronic obstructive pulmonary disease due to your smoking, please respond. They're looking for people to share their story and help save lives. Over the past few years, we've had more than 25 people share their real stories on what smoking has done to them through the Tips from Former Smokers campaign. Those stories have inspired hundreds of thousands of people to quit smoking for good. This is your chance to join them and keep what's happened to you from happening to others. If that sounds like something you might be interested in, you can either email contact@joincdctips.com or call 844-274-9816, and I will also make that information available to you in our wrap-up email in the next day or two. So tonight it is my distinct pleasure and honor to welcome somebody in the first of our MD series who I have known for probably at least 16 years, if not 18 years. Dr. David Kamelhar is somebody who is a very unique individual in the field of pulmonary medicine. Being at the Pulmonary Wellness Rehabilitation Center, we get a very good bird's eye view of what type of physicians, of what different physicians are doing with their patients. And one of the things that is most amazing about you, Dave, is, and what people should know about Dr. Kamelhar, is that this guy is so comprehensive. And when people talk about your care, they use words like sleuth, detective. They say things like great diagnostician. I always associate you kind of with Gregory House, MD. Because I've known so many patients over the years who have been to multiple pulmonologists, and they come here and they say, I'm still coughing or I'm still short of breath, and they don't get relief, and then they go to you, they go to Dr. Kamelhar, and this guy is relentless in figuring out what their problems are. So I'm really honored to have you as our first guest, and so let's get started with Eat, Cough, Breathe, the relationship between the GI and the respiratory system. So first of all, Dr. Kamelhar, between the neck and the waist, there are a lot of organs and systems. With this in mind, I think there are many people who really don't appreciate the relationship between the respiratory system, the GI system, and how interrelated they actually are. And I know that your patients do. So can you teach us about that? Tell us about the relationship between the GI system and the respiratory system.
Well, I have to begin by thanking you for your effusive welcome and compliments, and hope that I can live up to any number of them here today. I think one of the monumental works in terms of bringing to light the interaction between the respiratory tract and the digestive tract came, I would say, probably 20 years ago. Or so. The American College of Chest Physicians came out with a position paper, and they've had updates with that, stating that the most common cause of chronic cough is reflux, and put a little more broadly, what they call the UACS, the upper airway cough syndrome, and the upper airway cough syndrome, or the UACS, puts forth the notion that most chronic coughs start in the area of the voice box, and that some combination of sinus disease and postnasal drip and or gastroesophageal reflux, which I'll spend a minute talking about, defining, that's where most cough starts. And since the most common chief complaint that brings patients to lung specialists, and one of the most common complaint that brings patients to any physician is cough, it started people thinking. Let's define terms. The esophagus is a tube, a connection between your swallowing, which is up in your neck, and it passes all the way down the middle of your chest to your stomach, which is below your left rib cage, sits beneath the left lung where the rib cage ends. And the passageway or the passage of food is supposed to be a one-way passage. Food is massaged down, similar to your bowel. There's your intestine. There's peristalsis. That the food has to be massaged down, has to be squeezed down, and it's supposed to only go down. It's not supposed to stop on the way, and it's certainly not supposed to come back up. So anything that comes back up is called reflux. The interaction between the esophagus and what goes on in the respiratory tract has been investigated since then, with still as many questions as answers. It's still in a stage of investigating and understanding. The ear, nose, and throat people, the ENT people, use a term called the unified airway. And that's really more a term of the ENT literature than the pulmonary literature, stating that the sinuses, the voice box, the bronchial tubes, and the esophagus are all connected and interactive one with the other, one with another, as one large system rather than four systems that happen to meet at the windpipe, at the throat, I should say. And how these interact is really what people are investigating. So the esophagus is situated right behind the windpipe, right in front of the spine, and as it passes down the middle of the chest, right in the middle between the lungs, it passes behind the heart, and that's why people get what they consider to be heartburn, because it sits right behind the heart. So if you feel in the middle of your chest, people think of as being a burn in the heart, when in fact it's irritation of the esophagus. So the symptoms that most people are familiar with are heartburn, agita, burning, squeezing, lower down, and most of those people will not come to the lung doctor. They'll either take Tums or Rolaids or some preparation on television that's all over television all the time because it's so common. And the people who have what we call laryngopharyngeal reflux, or silent reflux, or reflux higher up, those are the people that come to the ear, nose, and throat people, and the lung specialists with coughing and wheezing and short of breath and chest tightness and arm pain and back pain and shoulder pain, sore throats, dry mouth, voice change, sinus problems, recurrent sore throats, recurrent respiratory infections, and the like. And really, it is the job of the detective to try to tease all these apart and figure out how much of which is which, and with the broad principles of, number one, that common things are common. So lots of people have reflux. That you go by the principle of and not or. That it's not one thing; it's many things put together, and so on. And I'm sure we'll talk about it as we go. How you investigate this and what clues you get when you talk to a patient about how to put all this together. So it's a kind of a long question. It's not the whole answer. Long answer, I should say. It's not the whole answer, but I think it gets a conversation started about the interaction between the digestive system and the respiratory system, and for that matter, the ear, nose, and throat system.
So that's a great point. A lot of great points there. There's a lot of information there. So just to make sure that I understand this correctly. So what I think you're saying, and I didn't even realize that cough is the number one symptom that brings people here, but as you mentioned, you have cough, you have heartburn, you could have chest squeezing. So when I see a patient for the first time, my risk stratification is always, we want to make sure it's not the heart. So I'm always looking to risk stratify for coronary insufficiency. I'm looking to risk stratify for arrhythmia. I'm looking to stratify for heart failure, because these are the things that are going to be the most dangerous during the rehab program to our patient. What it sounds like you're saying is that between the ear, nose, throat people, because we have post-nasal drip and we have other things in the nasal sinuses, the gastroenterologist, the pulmonologist, people can almost enter the system in many different pathways. My question then is how do we make sure that they're getting to the right person? So how do we make sure that the cough is, because you're a pulmonologist, but I always hear you talk about the GI system. I always hear you talk about ENT, and you're somebody who I know works with everybody. You get right on the phone. If you have a question, you call somebody, you say, this is what I want to do with this patient. And that's brilliant. I think that's one of the other keys to your success, is that you know exactly how to sort of narrow down who should go in what channel. How do you do that? And as a patient out there who may not be in a situation where they have access to all these specialists, what should a patient be looking for and what information should they be communicating with their doctors to make sure that we really, the heart goes to the heart doctor, and the GI goes to the gastroenterologist, and then the respiratory system goes to the pulmonologist.
Well, that's a lot of. This time it's a lot of question. I gave a lot of answer. Now you gave a lot of question. I think the most important thing to remember is that the history is the most important thing. That you can have pain in any part of your chest, and it could be squeezing or stabbing or sticking or burning, and there's no foolproof way of knowing what's what. So certainly somebody has a squeezing, pressing pain on the left side of their chest, and it travels up to their neck and goes down their arm, and it's a 60-year-old cigarette smoker who is doing some form of exercise, perhaps that they don't usually do, and it happens when they start, and it stops when they stop. I think most people would recognize that person has angina or heart pain till proved otherwise. But it's not always that easy, and in fact, it usually isn't that easy because most people are smart enough to figure out a lot of it themselves.
You mean patients?
Yes, patients.
Okay.
But not always. And I think it's, yes, patients should be educated, and patients should be engaged, and patients should be involved in making the right decision. But I think it's the physician's job, it's the physician's responsibility to be the one to figure it out. So whatever the patient comes with, if it turns out it's a gastrointestinal problem and they come to the lung specialist should be smart enough, to figure out where that direction goes. And it's really a combination of the history and, as you say, a risk stratification. So a 60-year-old who has chest discomfort or chest heaviness, even if it doesn't fit the bill exactly, you really do need to exclude the heart. They say it's cardiac till proved otherwise.
Absolutely.
Because you can always live one more day with heartburn or reflux. But if you miss a cardiac insufficiency, the next time that person has the symptom, that would be a bad phone call for somebody to get a bad oops and say, oh, I guess it was the heart. I guess maybe we should have gone the other way. So today, the last patient I saw before I came here, and this is, this happened, this is the real story, 24-year-old young man with no history of any risk factors other than perhaps a family history of cholesterol, whom I ran into. He's a friend of the family, whom I ran into about 2 weeks ago, and he told me that he decided it was time to get back to exercise. He recently got married, and he had started a stressful job, as it were, in finance, and he went running, and he got left-sided chest discomfort. And the first thing you think of, 24 years old,
Right.
thin fellow, it's not his heart. So I said, just come by, we'll take a look at it. It's probably reflux, because you can, when you're running, you kind of bounce your stomach up and down, and things can go up and down. And there was a big article in the New England Journal about 30 years ago about a fellow with chest pain. It turns out it was reflux. But we all see this now, recognize it. So he came by today, and he said, I just, it happened one more time, and I got a little nervous. So come on over, we'll take a look at it. And lo and behold, he told me the story, and he said the only time he ever gets it is when he runs, and it's predictable, and it's patterned. It's the same way, the same time, the same symptom, always here, always when he starts running, goes away when he stops running, and it's happened half a dozen times. And I said, I'll bet you everything in my pocket this is not your heart, but you better do a stress test.
Find out.
You just better do a stress test, because there's no reason why it should be in a 24-year-old thin fellow, non-smoker, why it should be your heart, but that would be a very bad miss. And it just,
Absolutely.
as they say, it didn't pass the smell test. It just didn't smell kosher. And then after that, we'll get to the reflux, and we'll get to the other, and we'll get to the other. So, there's never and never and always, and you always have to keep your thinking cap on, and you always have to, as I said, you have to have a sixth sense of what just adds up and doesn't add up. And in terms of getting the history, it's a matter of knowing what questions to ask, trying to find patterns, and very often finding out what doesn't fit in the story. They'll give you a perfectly story. Say, wait, go back and tell me that again. That you get this symptom when you're doing what? That you always get it when you're lying down but not standing up and lying down. It never happens. Somebody always gets a symptom when they're at rest and never get it with exercise. I said, well, that shouldn't be your heart. That doesn't make sense. It may be a perfect story for your heart, and maybe, yes, we should do the stress test, but you don't get heart pain when you're sitting still, and then you go on the treadmill and go to the gym and work out for 2 hours, and it doesn't happen. So always find what doesn't fit in the story, and try to make sense of it.
And it sounds like we're really on the same page in the sense that, you know, I believe that the first visit, the first hour I spend with my patient is really the most important hour, because if you don't ask the right questions, if you don't get it right then, and, you know, of course we're always learning about patients as we develop a relationship with them, but if that first hour we come up with the wrong hypothesis, then everything we're going to do after that is going to be, you know, go along with that wrong hypothesis. And as you said, you don't want to make the big mistake, oh, I thought it was reflux and it actually was the heart. You've been in practice, I mean, you're certainly a seasoned veteran, all-star physician at this point. Are there still things that you do to prepare before you see an initial patient? Then, you know, do you like to read the chart ahead of time? Do you like to get your own opinion and then look at the records later? Do you have a style for that?
Just one comment I would make about the first visit is the most important. The first visit is in many ways the most important because it starts you off in a direction. But the fact is that when you do the first visit, it includes family history and lots of things that often are seemingly extraneous to the story, but you need to get it because you need to know everything. And very often the patient says, what do I need to come back for? I already told you the story. Why asking me again? Because the second time you kind of sifted through a couple of things, you did a test or two, and you have some facts now. Let's go through this again. Let's get to the meat of the matter. So what exactly, just describe the symptom without all the rest of the stuff. Just let me hear it one more time. Let me get the pattern in my head better so I really understand this. And also the patient often, you will have asked questions of that patient that they never thought of. You know, the first time they came. They'll come back and say, you know what, I paid attention to that. I never really thought about that way. But you notice, you know, when I was paying attention, and lo and behold, it does happen when I do this, and it doesn't happen when I do that, and I never really thought about that before. So the second visit, and often recurring visits, but certainly the second visit in a complex story has its own special worth. As far as what do I look at? If somebody's coming to me because they have an abnormal CAT scan, that's their complaint. My doctor said I have an abnormal X-ray, I have an abnormal CAT scan. Where the scan is Exhibit A, that's why they're here. So I will often, if I can, look at the scan first. So when I'm asking questions, you know, you ask everybody every question, as it were. But you certainly try to triage your questions in terms of if something on an X-ray looks infectious, you'll ask questions about more infection. If it clearly looks more like a growth, if you wish, but you certainly ask the others anyway. So it kind of takes you in a direction. But if the patient is there for a story, for a history, I'm coughing, I'm wheezing, I'm coughing blood, I can't breathe, I want to hear the story first. I want to get my own impression, and then after that, let me see what everybody else's impression was. You know, read the chart that they bring, and sometimes patients bring lots and lots and lots of charts. But everything is edited. Don't you want to know what Dr. So-and-so said? No, let me think about it first, then I'll see it. You want to have your own first impression. You want to think about it fresh yourself. And you never think about it as clean and crisp as when you get the history yourself. Reading anybody else's chart is always edited, biased. You know, send me a doctor's record. Why don't you call my doctor? He'll tell you. Why don't you send me the records first? Let me read what he or she found, and then I'll call and ask a question about it. So let me see what the facts are. What are facts to me? What are opinions to me? Try to draw my own conclusions. So unless the scan is why they're there, or the X-ray is why they're there, or the culture of their sputum is why they're there, I want the story first, and everything else comes second.
Great. I mean, I like that, and you know, you're a super confident doctor. So you know, there are some that are less confident, but that makes perfect sense. Now let me ask you this: speaking directly to the patient now, what are some advice that you would give to a patient before they see a physician for the first time? Because, you know, we want to maximize the time that we spend with you and make sure that we don't forget to tell you anything, and that, you know, that we make sure that we give you the information that you need. So what would you recommend people do to prepare themselves for the visit with you?
Well, that's a loaded question, because, you know, it goes both ways. Patients often come with 5 pages of a chronologically ordered, you know, almost day by day and week by week, starting in 1964, and they feel the need. Well, don't you want to read this? Don't you want to hear that? And if you're a physician and you have a complicated story, they always, especially they teach in medical school, let the patient finish what they have to say, let the patient present it the way they have to present it, and really one of the things that comes with confidence, and you have to, maybe sometimes I cross a line, I try not to, but as you get a little more confident, sometimes you'll tell a patient, why don't you let me guide it? I know you prepared a lot of material, and you thought about it a lot, you put a lot of time into this, but from my way of thinking about how to solve a problem, there is an order to do it. There's an algorithm, there's an order, there's a logic, and no disrespect intended, you do what you do and I do what I do, and I wouldn't tell you how to investigate what you investigate, so why don't you let me kind of lead you through, and if at the end of all that, make sure that you tell me everything you have to tell me. I don't want to be a bully about this, but sometimes you have to lead the conversation if it's going to take you in a direction, because otherwise it just takes you off on too many side roads. So that, in terms of the confidence issue. But, if you're coming to a physician to talk about a topic and you've had images done, especially X-rays, CAT scans, and so many people have had scans done, bring them with you. A report really, a picture's worth 1,000 words, and one person says is irregular in shape, to me is regular, or vice versa, or, you really have, that's the way you form your own opinion. Because once you read the report, people have a concept that, well, the report says this, so why don't you believe it? Because the person who wrote the report is a person too. He's a physician, she's a physician, I'm a physician, they're entitled to their opinions, and the idea, just because it says it black on white doesn't mean they're correct, it's correct.
Right.
But the radiologist said, but the something said. They're people too. So again, start from the beginning. Start from the very beginning. See the images. See the everything. Call the person who did the echo. How confident are you that the echo really shows this and it's moderate, not mild, mild, not moderate. Come with a lot of information. Try to organize it in some way. Specifically, pictures, images, X-rays, CAT scans. Bring too much, not too little. Don't be the editor, let the physician be the editor, and it takes a lot of time to be an editor, but at least you know what you're editing. So come with a lot, be prepared to listen, try to keep an open mind, and let the physician try to guide you. That's really what the physician's job is to edit.
Absolutely, great advice. One other question, is there something that you find is overlooked often, like something that you say, no one looks for this, but here it is, because there are certain things that I hear that seem to come out of your practice a lot more than I hear, many people discuss it, things like NTM, things like bronchiectasis, it's not so much the sort of garden variety COPD, but they're always sort of COPD with this, and this. So what is the secret to that, and what is what is the process, or what should patients be, when should they say, maybe something's not right here?
Well, that's also a tough question to ask, because when you see the world through certain glasses, you have to make sure that you look for other things as well. So bronchiectasis is defined as a weakening in the wall of the bronchial tube, and because the wall of the bronchial tube is weak, the bronchial tube becomes wider and doesn't conduct air the way it's supposed to. And it doesn't conduct air the way it's supposed to, it doesn't keep the air clean. It's sort of like a varicose vein in your leg. The wall of the vein is weak, and there the vein becomes wide, and the blood stagnates, and then you get swollen legs, and you get fat veins, and over time it gets worse and worse and worse as you get older and older and older. So it was a little thin, wide vein when you had your kids, and then, when you were pregnant, and then it kind of went back to okay, except for a little line. Then you're 70 and you have this big fat ugly pipe in your leg. The same thing happens with your bronchiectasis, that it probably happened when you were young or younger than you are now, and then statistically over time the curve shows that it gets worse and worse and worse, and when you pass 55 it gets much worse. The likelihood that you'll present with a problem related to that bronchiectasis, chronic cough, chronic sputum, that sort of thing becomes much, much, much greater. So taking the example of bronchiectasis, if somebody says that they have 6 chest colds a year and they're always coughing up mucus, and they were told they have chronic bronchitis. Well, wait a minute, were you ever a cigarette smoker? No. Then why would you have chronic cough with sputum production? And why do you have sputum all the time? And why do you have these infections? And why do they linger? And why do you get 6 Z-packs a year or whatever it is that you get a year? You have to take a step back and say, this ain't natural. Something's wrong here. Dig a little deeper. Oh, I've had lots of X-rays. Well, you don't find bronchiectasis on an X-ray. You find it on a CAT scan. Sometimes you need a well-done CAT scan. Not all CAT scans are up to par. And you need a radiologist often who's used to reading it. Some physician who's not familiar with it will read it as a scar, when in fact that line is not a line, it's a double line. And that's a dilated bronchus and not a scar. So, you have to be familiar with these things. You have to know what to look for. Because if you don't know what to look for, you're never going to find it. People will have endless numbers of chest X-rays, and every one of those X-rays is what we call a so what test, because it can never answer the question. If you have a chronic condition, there is no advantage to doing an X-ray. It won't show it. It won't show it. So you have to do the right test in the right situation. And the same thing, you made reference to NTM, or non-tuberculous mycobacteria, which is a subgroup of bronchiectasis, which we can talk about separately for a whole evening. We can talk about it in a minute if you want. But again, if you don't look for it, you're never going to find that on a sputum culture. If you do a routine culture in a routine lab, requested looking for a strep and staph and pseudomonas and all the things that people look for, that culture is not capable of detecting mycobacterial infection. So you can have cultures from now till whenever, and X-rays from now till whenever, and if it's not in the front of your brain that's what you're looking for, and that's included in your search, you're not going to find it. So if somebody comes and says, I started coughing last Wednesday, and it's A, B, C, and D, it's fever, no fever, sputum, no sputum, wheezing, no wheezing, I never had it before, I'm a healthy person. There's no reason to look for those things. When somebody gives you a story, it's been going on for months and years and happens again and again, you have to think a little broader than here's another course of antibiotics. And why would you have that?
So, this is great information, and I feel like I'm in school right now learning from you. And the question is, we have patients from all 50 states, and we have patients from other countries that log on to our program. As a patient, I think it's often very difficult, because you go to the doctor, and as you said, you want the doctor. You go to the doctor for help, and you say, this is my symptoms, or these are my symptoms. And I hear it from people all the time, is no one ever asked me this, or no one ever told me this, or this is the first time I'm hearing this. What advice would you give to somebody who, let's say, lives in a small town where maybe they don't have access to the big medical centers or the specialists, and something doesn't feel right, but we're supposed to trust you, you're the doctor, right? How can that patient make sure that they're getting adequate care? And when should they really say, maybe I'm not getting what I need to look elsewhere?
I don't like that question.
Don't answer it. It's okay.
That's a very hard question to ask. I'm very privileged. I practice at a medical center that has one of the very, very, very best chest radiology departments in the country, with the person who's probably written more about bronchiectasis and airways disease than perhaps anybody else. And he leads that division, that department of radiology. So I'm biased. I'm in a medical center where they have a dedicated lab for this mycobacteria, and where we have a dedicated chest therapy, and I have access to pulmonary wellness chest therapy. So it's privilege, privilege, privilege. It's very easy to be smart when you have people working with you who are very smart. That's a very hard question. I don't know the best way to answer that question. I think that one of the problems that I find that patients often run into is that they go to a physician, and that physician sends them to the next one, and that one to the next one, and that one to the next one, and that one to the next one. I think one of the things that has to be built into any system of care is that when you send to somebody else, somebody has to be at the center of the hub of that wheel, and it has to come back to me. I'm sending you to him, her, and that response comes back to me, and you come back to me. If you have a cough, I will take ownership of that cough. Now, do I solve every single time? Nobody can solve every single time. Nobody. You do your best. But, if I see that physician's report, I send to my best EMT person or my best whatever it is person, and what that person sends back to me kind of doesn't make sense and doesn't fit, I'll call that person up and say, wait a minute, can we talk about this? You got to hold people's feet to the fire, and they have to be accountable for, I know you're saying this, I know you're not from this, but it walks like a duck and quacks like a duck. This person's having this symptom, it happens at this time, they cough right after they eat, or they cough while they eat, and even questions like that. So you're coughing in relation to eating. Is it while you're eating? Are you still at the table putting food in your mouth? So in which case maybe it's a swallowing problem, or is it an hour after you leave the table and then you start coughing, in which case it's probably an esophageal problem, for instance. You really have to get into the very detailed details of the story and see where it takes you. But you have to find a physician that will take charge of your problem. And not everybody, as I said, not every physician is as privileged as I am to practice where I do. And if I don't have what I need in my medical center, I send people to the other medical centers in the city, or in the East, or in National Jewish in Denver, or it's about the patient. It's not about me. It's not about my colleagues. It's not about anything else. I'm accountable to the patient, and I'm there to solve their problem the best way I can. And I will not send somebody off, to another part of the country or another part of the state, or even another part of the city. Here, take this doctor's name, and you tell him I said to go to you. If I think it's that complicated, I'll call that physician and say, listen, I have this patient. I think this is what's wrong with him. Sounds right to you? You think you can help out? Fine. I'm sending him up to you with the information. So it's not fair to the patient to send him running around, and then they get to the doctor says, that's not really, I think Kamelhar sent you to the wrong guy. That's just not fair. So I have my responsibility too.
And that's something else that I think is so impressive about your practice, is that you work with everybody. You know everybody in the city. You work with other hospitals. You'll work with other medical centers. And you didn't like the question the first time, so I'm going to try to hit you with it in a slightly different way, because I know there are people out there, and I'm now operating on behalf of my constituents, and I know there are people who are listening to you talk tonight, and they're going, you know what, that sounds exactly like me. So again, I ask you, I am in no disrespect to any state I'm about to mention, because I'm a citizen of the world, but I'm in a small town in Kansas. I'm in a small town in Texas, Florida. I'm in a part of Brooklyn, which can seem like different parts of the world. But what can these patients do, and when should they say, you know what, I'm going to make it my business to go to National Jewish, or I'm going to make it my business to go to Mayo Clinic? And again, for the person listening at home saying, you know what, that sounds just like me, what's the one thing you would say to them? What could they do? You like it more this time?
No. And I don't like to be hit either. Again, in the ideal world, everybody would have everything they need right around the corner from them. I think there's a limit to how, again, I'm not from Brooklyn, but somebody is, and they're not going to like you. So you may get hit also.
I'm from Brooklyn.
Okay. I think, as I said, I think a patient has to feel that they're satisfied with the care they're getting. And very often they'll have a small problem. It's sort of in the eye of the beholder. What's a big problem to one patient is a small problem to another patient. And a patient may come to you with a cough that's been going on for X amount of time, and you watch them and they're clearing their throat or they're coughing, whatever it is, and you're looking and saying, how the heck do you live like that? How do you conduct your life like that? And they'll say, it really doesn't bother me. I just want to make sure I'm not dying of something. That's all I want. So you have to also understand, why are you here? I know you have a cough, but the cough bothers you because it interferes with X or what? So you have to understand that part of the question too. You always try to. Sometimes you need to educate the patient to that also. And I'm still not answering your question. You need to educate the patient to the fact that, by the way, you don't have to be coughing all the time. I know you've been coughing for 30 years, but it's not necessary. I think we could do better with it. Really? I thought that's just like part of me. It's like my bad back. I just accept it. No, we based on what I see or hear, I think we could try to do better, or your throat clearing, or your hoarse voice, or your shortness of breath, or whatever it happens to be. I think, again, not everybody has access to every resource. I think in today's day and age of internet, and today's day and age of email and so on and so forth, major world centers like National Jewish and the Mayo Clinic all have kind of intake nurses, and you can send them a question, and is this the reason I should be going to you? But not everybody can go there either. I mean, I just to have somebody pack up and go to another part of the country, they have family, they have jobs, they have financial responsibilities and financial limitations. I think you just have to try to, like you do everything else, you just have to be as smart as you can be and be an educated consumer and ask as much as you can ask. I don't know how to, there isn't a one-size-fits-all answer for that. Why do some people get cheated by stockbrokers and their pensions get not do as well as they should? How can people have access to the best? And you can only be as and I don't think it has to do necessarily with your education or financial background only. Some people just seem to do better at things than others. As I said, I don't know that I can answer your question very specifically in a one-size-fits-all way. So I think I've done the best I can. I'm sorry.
Okay. So I'm going to ask you one more time. No, I'm just kidding. So let me ask you this, and this is something that I would love to know more about myself, and I'm sure people want to know about this because I get questions about this all the time. Can you talk a little bit about the difference in cough between, let's say, your chronic bronchitic versus your emphysema patient versus your pulmonary fibrosis patient versus your lung cancer patient? Because I know that for some, as you mentioned, that could be their number one symptom. Like we have patients who they get up on the treadmill and they could spend 17 out of 20 minutes just coughing. And often it's more the patients with the restrictive diseases where it's just this sort of spasmodic cough. So can you tell us a little bit about that and what people can do to sort of make that better?
Well, first, in terms of trying to get a pattern of the cough that's foolproof in terms of what drives it, again, you get to a point where a cough is a cough, and just to take a step back from cough. I mean, the reason the good Lord above, or whoever it is that designed things, however we got where we are, cough is like pain. Why do I have pain in my finger? I wish there were no pain fibers in my finger. Well, if you stuck your finger in the hot water and forgot to pull it out, you'd be in trouble. So if you went to a room filled with all kinds of terrible smoky stuff, or there was some chemical in the air and you just kept on inhaling it and didn't cough and close your bronchial tubes and try to expel it, or a foreign body was in there, a crumb or a piece of something got in there, that would not be advantageous to you. So cough is kind of a desirable reflex, desirable bodily response that's become uncontrolled or past where you want it to be. Very often the pattern as far as a cough goes, you can judge from talking to a patient. First thing I do is where does the cough start? And you just don't lead the patient. Keep your hands on the table. Don't point them. Does it here? Does it here? Does it there? So just point with your left index finger or your right. Where does your cough start? And if somebody says, "Doc, it starts right there," it does start right there. Never wrong. Never say never. But that's what I call a throat pointer. You're a throat pointer. That's where your cough is from. Almost always. What is it that makes you cough? Is it when you walk or you talk? It's when I talk. It's right there. Because when you walk, you're using or exercise, you're losing a lot more lung than when you talk. When you talk, you're using up here. So when somebody says, "I'm in the middle of a conversation," and all of a sudden I start doing that, that's almost always up there. And when somebody says they have a coughing fit, I said, "Do you cough onesie, twosie coughs? Just one cough at a time, or you really all of a sudden start, and you just can't stop, and it runs away from you?" That's up here also. What relieves it? I take a sucking candy. That's not your lung. I take a sip of water. That's not your lung. Now, if I'm examining somebody, or they're clearing their throat all the time, and very often patients don't even realize it. You clear your throat all the time? No. Honey, you do clear your throat all the time. You just don't realize it, just like you're doing now, honey. And the person doesn't even notice it anymore, or the little cough. If you ask a person to take a deep breath when you're examining them, and every time they take a breath, they cough, that's almost always up there. As the air passes through the up there, I find that that's often always what we call an upper airway cough. When you get past that, obviously if somebody's got lots and lots of mucus, the mucus has to come from somewhere. So you try to get a sense, unless it's really dripping down and the person's you should probably hawking it out, walking it out, whatever it is. most copious mucus, lots of mucus comes from down below. If there's wheezing, if there's crackle in the lung. But, as I said, they're not either or. In other words, you can have somebody with scarring in the lung or pulmonary fibrosis, and that pulmonary fibrosis can be, a consequence of that can be bronchiectasis. What we call traction bronchiectasis. There's nothing inherently wrong with the bronchial tube, but the scarring process that's in the lung pulls the wall of the bronchial tube open. The bronchial tube wall isn't weak the way we described it before, but it's being pulled on. So all of a sudden you have a wide bronchial tube. So now you have two diseases in one. Another situation where you need a CAT scan, well done, well read, well interpreted, and then that person, by the way, can get all the other things that people with bronchiectasis get. Infection and mycobacteria, and. So, you always have to think broadly. So again, there's no one pattern that fits everybody. You kind of have to think about what else there is. It's not just the cough; it's the cough and the breathing test and the physical examination, and the pattern. When does it happen? It happens when I lie down. If it happens when I get into bed, I put my head on the pillow, I start coughing. I mean, that's either postnasal drip or reflux, and in my experience, it's more likely reflux. Do you lie down right after you eat? Yeah, I come home late. That's the life we all live. I come home late. I eat dinner at 9:30, and I'm exhausted. I got to get up at 5, so I eat dinner and I go to bed 15 minutes later, and I'm coughing in the middle of the night. That's your reflux, because gravity. It makes you even have a chance to digest yet.
And what about the patient who gets woken up in the middle of the night by coughing? So they go to sleep, they have no trouble falling asleep, but they have trouble staying asleep because they're coughing.
I think, obviously this, you can have cough variant asthma where it's asthma but it presents as cough, or heart failure can present as cough. So, certainly an older person, with what they call paroxysmal nocturnal dyspnea or orthopnea, that they lie down and they get short of breath, or they sleep on 3 pillows, and that may kind of migrate, that may kind of morph into wheezing or morph into coughing. But kind of the more, the standard otherwise healthy person who has a nighttime cough, same thing. It's the same positional. Is it very positional? And very often you have to dig deeper. You ask a person, what about exercise? What exercise do you do? Do you swim? Yeah, I only cough when I swim. I don't cough when I'm on the treadmill. So what's the difference swimming on a treadmill? When you're swimming, you're in the horizontal. No, you're in the horizontal position.
Gotcha. Okay.
When you're on a treadmill, you're in the upright position. So it's less likely to provoke reflux. So you always, you just learn the tricks. So certainly a cardiologist has better cardiology tricks than I have, and I have better pulmonary tricks than they have, I would think. And so it goes. You get to learn the trick questions that cut right to the matter.
How important is hydration, and versus, let's say, so people come to me all the time and they say things like, I don't drink enough water, so obviously that's going to make the cough thicker or things like that. But then also people will ask about things like Mucinex and things of that nature. What are the key points there in terms of helping them improve their coughs without knowing them, obviously?
Well, I think, you're kind of either a believer in that or you're not a believer in that, and I'm a believer in that. I think, the tenacity, the thickness of mucus is a big culprit, and I think especially, whether it's getting stuck on your larger airways, like on your vocal cords or in your bronchioles. Sometimes you hear people cough and you listen to the stethoscope and everything is clear down below, and you listen in the front, and all of a sudden you just hear like a sticky sound really very high up, and the answer is that the mucus is just too thick, that they cough as forcefully as they can. They'll have a normal X-ray, they'll have a normal breathing test, and everything's normal, but you listen way high up in the chest and there's just a vibrating sound, a whistling sound, really, it's a sticky sound. Again, talk about believers and non-believers. Either you're a Mucinex believer or you're not. Mucinex is guaifenesin, which is, without plugging a particular product, people know it's Robitussin. It's a mucus thinner. Robitussin is not a cough suppressant. It's a mucus thinner. And the way it suppresses cough is by helping people get rid of their mucus. And sticky, thick mucus makes you cough. Except when the mucus is thick and sticky, the cough is not effective in clearing that sticky mucus. It stays there. In terms of important things that happen other than kind of discomfort. Sticky mucus clogs up your sinuses. Sticky mucus, especially people with chronic airways disease and bronchiectasis, where they have trouble clearing their airways. It's not unusual for patients, and I've seen this, every from now and again you see a very dramatic case of this, like in a hot spell in the summer when it's 90 degrees every day. People will come in, and I've had patients actually block off an entire lung, and it was nothing but sticky mucus. That's the whole thing. Nothing but they just didn't drink enough, plain and simple. Very often an older person did not drink enough, and they got into terrible trouble in the setting of having underlying lung disease just from not drinking enough. So again, I believe in hydration and keeping things fluid, keeping it flowing.
Great. Okay, thank you. I'm going to go to a couple of questions that came to me during the week in anticipation of this talk. So there's a couple of questions here, but I think the most important part is I wear my oxygen when eating, but still have breathing struggles at the end of a meal when I move around, stand up, or walk. Did I eat too much, or was I eating the wrong type of thing? I also hear that soda and wine are not good when you have COPD.
The answer is yes. Certainly eating a lot fast. I mean, everybody at the Thanksgiving table, at the end of the 18-course meal, all the men are pushing themselves away from the table, opening their belts, going, "I ate so much, I can't breathe." Well, there's nothing wrong with your breathing. I mean, if your stomach is here underneath your left lung, and it's distended, it's swollen with food, especially food that got in there real fast all at once, more than you used to, it may push up on your lung, and you may feel it's just something that's inhibiting your ability to breathe. Similarly, if your esophagus is full, again, as we talked about before, your esophagus runs right down the middle of everything. So if your esophagus is a little bit stretched, you're not used to the sensation, you're not used to feeling. So you may feel like a fullness, you may feel like something swollen in there, or something that's interfering with your breathing. A sense of being breathless does not correlate well with any one thing. So I can't breathe, that my oxygen must be low. I can't breathe, I must need my inhaler. It's not necessarily so. Breathlessness, shortness of breath is a sensation just like pain, just like a palpitation. There's no one thing that it corresponds to. People, after they eat too much, their stomach may be distended, their esophagus may be full, they may be having reflux. Reflux is sometimes sensed as breathlessness. That's not unusual for me. And just getting back to more, fancy science and cardiology, if the blood flow, if you have limited blood flow and your heart doesn't work quite right, and the blood is all flowing to your digestive system, your intestine, to digest all that food, you may actually have some trouble when you're trying to walk around, because that's where all your blood flow is going. It may put a demand on your heart. So it's kind of, again, it's all of the above, any of the above.
Gotcha. Okay, great. So we're going to go to a couple of questions from the home audience from tonight, and if Nicole, if you could lead Dr. Kamelhar in, we're going to accept hopefully only meatballs tonight, so we're going to give you only easy ones. So.
Okay, we have one question that was about what kinds of things show up on X-rays. For instance, does bronchitis show up? Does emphysema show up on an X-ray?
If I could maybe add to that also, because these are some basic stuff that people always want to know. So what will show up on an X-ray versus what do we have to go further for a CAT scan?
In terms of the chronic conditions, will show up less distinctly and succinctly on an X-ray, and less specifically. So let's take bronchitis. So bronchitis on an X-ray may be seen as a thickening or accentuation of the bronchial tubes, right? So an X-ray is really a black and white entity, and it's a contrast between the two. So things that you may not see when they're nice and thin, like a thin-walled bronchial tube, all of a sudden appears once the thickness of that bronchial tube becomes wider. The thickness of each wall becomes wider. So you get a sense of what they call a busy X-ray or a dirty X-ray, because you just see more than you should see. But again, that's also dependent on a lot of other things. The technique of the X-ray. If somebody's a short, squat person and can't really expand their lungs very well, it may make their lungs look busier. because the normal blood vessels and bronchial tubes will be kind of squeezed together, while a tall, thin person may have tall, thin lungs. And that X-ray will be read very often as what they call hyperinflated or too much air in the lung, when in fact they're just tall, thin lungs. So you look for other clues as to what's what. Most emphysema will not show up on an X-ray. Most emphysema is what we call centrilobular emphysema. It's just very small areas of extra air, as against big bulli, or what we call bullous emphysema, where there's the kind of the upper third of the lung, just one big air pocket. That may show up better, but that's not what most people have. So again, you use your X-ray as a tool. It may give you information. You have to figure out almost any test short of a biopsy of a mass, and even then that doesn't always give you the specific answer. But tests like X-rays, like cardiograms, like blood tests, they're tools to take you in a direction, and it's the job of the physician to figure out how to use that tool. And when that tool has given the physician enough information to stop there or go further. So again, same question in terms of when do you stop with an X-ray and go to a CAT scan? The answer is it depends. It really depends on what's the question you're asking, and what's the chronicity of it, and how does it fit with everything else. So if somebody has a perfectly normal breathing test, and their breathing test doesn't show any abnormality that suggests that there's emphysema, such as there's extra air in the lung, or there's narrowing in the small bronchial tubes, or whatever, and you have a tall, thin patient with tall, thin lungs, and the radiologist reads it as hyperinflation lungs, I said, yeah, but the breathing test doesn't show hyperinflation. Right? So, as the metaphor I use for patients said, you walk into an exam room and somebody's, gentleman sitting there wearing his pants or his undershirt, or his undershorts and not much else, and you're standing across the room and say, boy, this guy looks a little chubby to me. And you say, get on the scale. I say, well, okay, not weighs what he's supposed to weigh, just a visual, just a clue. And it's the same thing with this. It's a visual. It gives you a sense of what's what. If you weigh 400 pounds, you're not chubby. You don't need a scale to know this person's overweight. You want to know how much. So you put it in the context of everything else about when you need to go to the next step.
Gotcha. More questions?
We have another question about when you visit the doctor. Does it help to bring a list of all the drugs and the supplements that you're taking to that first meeting?
That's a point that's very well taken. Yes, it is. And it's important in addition to the list. How many milligrams? What time of day do you take it? How long have you been on it? That sort of thing. That's very, very important. And I'd rather have a patient come with a bag of pill jars than nothing. Because it takes me a second, or somebody in my office, it really takes a minute to get that information. And sometimes you'll choose, this is not important, I don't need to know everything, but I at least have the option of knowing, let me be the editor, let me figure out what's important to me. One of the areas you kind of get into trouble, I take homeopathic stuff, which, I'm not inherently against, but, homeopathic preparations and over-the-counter preparations, my statement to the patient, anything that you put into your body that affects the way your body functions is a drug. Whether it grows on a tree bark or it grows in Pfizer laboratories, it's a drug. So yes, it is helpful to bring that information, to bring that with you in detail.
Got another question?
We have one more general question. Could you say something about why some people produce a lot of mucus?
Mucus is a reflection of inflammation, and it's inflammation that occurs in the wall of the bronchial tube where there are mucus glands. Again, if you have a respiratory infection, if you have an acute bronchitis, you caught something from somebody, once. And you started coughing and producing mucus, and it was colored or not colored, you had fever, that's sort of a normal process of an acute bronchitis. You may have mucus in response to an acute infection or an acute exposure. So if you're exposed to a chemical or some noxious fume or whatever it happens to be, you may have mucus as well for some period of time. Mucus that's ongoing obviously is not normal, is not kosher. Excuse me, you'd like to find a reason why it's there. It may be, we keep coming back to the same question of the same topic of reflux. And I think one of the things we didn't make enough, or didn't make too much mention of, is aspiration. In other words, when you swallow, it goes down the wrong way. That's some small fraction of what you're swallowing enters your windpipe instead of your esophagus, your food tube. Any of these things can cause mucus. So if you have diseased bronchial tubes that are chronically inflamed and chronically infected, like bronchiectasis, there may be chronic mucus production. And very often, if you can break the cycle and try to do certain maneuvers to clean the mucus, still waters run deep, that if the river doesn't flow, it gets dirty, and if you just improve the flow, it starts to clean itself up. Excuse me, if you clean up the flow, if you improve the flow in the bronchial tubes with various respiratory techniques, which, again, a separate topic, parallel topic, very often that mucus will improve as well. But mucus is always it's a reflection of some form of inflammation, acute or chronic.
Great.
We have a question then that relates directly to this, because a person asked when they're eating, they feel as if they will aspire food, especially something like rice. They say they try to eat slowly, but it seems to happen regularly. Do you have any suggestions?
I just want to modify one quick statement I made before, that there are forms of lung cancer that can present with sticky mucus. I mean, that's kind of the that's kind of the exception to the rule, and it's the exception to the rule in lung cancer as well. But I just want to make people aware that there are, never say never, and always there are exceptions to that. Anyway, so as far as I just want to make sure I understand the question, that not handling rice, that rice kind of irritates a person when they're eating.
They feel that they will aspire food, especially when they eat rice.
Aspirate, okay.
Sorry.
Right, so I think that goes back to the statement before about aspirating, about material going down the wrong way.
Yes, thank you, sorry, yes.
So swallowing is another one of those processes that we kind of take for granted, and well, what's the big deal? I put food in my mouth and I swallow it. What? Why are we analyzing this? The whole field of swallowing is not that old, and it really got started. I'll pick a number, 20 years ago, I guess. Maybe a little bit more, maybe a little bit less. Something like that. It became a popular topic when people had neurologic disorders or people had strokes, and the family would come around and feed the patient, and the patient would start choking, and everybody responded, "You got to tell the family they can't feed the patient. Don't they know he can't swallow? He had a stroke. He can't swallow. Don't feed him. He's aspirating. He's getting pneumonia," so on and so forth. So we've had since then, in the all or none of life, either it's normal or it's grossly abnormal, gradations of swallowing dysfunction. And the most common one is that of age. That as people get older, the organization of their swallowing isn't as efficient. And swallowing, again, I'm not a swallow expert, but I order a lot of esophagus tests, I order a lot of swallow tests because they're all germane to what I do. And the swallowing process, first you have to organize the material in your mouth, and that makes sure the tongue has to push it back evenly, and it has to kind of collect in one place. And then the musculature has to be able to propel it through the swallowing passage, and the protectors of your breathing passage when you swallow have to be in place so that it doesn't go down the wrong way. The little flap, the epiglottis, and again, it's much more complicated. There are all sorts of stages of this. But as people get older, those muscles can get a little bit weaker, and those stages of organization can become a little less functional. And then it depends on what foods there are. So the easiest thing to aspirate is water. Because water just, it's like trying to hold on to water in your hand. It slips through your fingers. It's a lot easier to hold on to mud than it is to hold on to water. Because no matter how tight you put your fingers together, some amount is going to drip through. So it's the hardest thing to control is water. So that's one type of aspiration. Then you say, well, what about, taking a big piece of meat? Well, again, you have to propel that down. So I can't get that down. Patients say, I can't swallow pills. I can't swallow big pills. So, there's something peculiar about that. Oh, I've been that way since I'm 2. Well, again, I'm not sure that I can tell why that is. So a little rice particle is, as I said, it's very hard to to organize a rice particle. It's small and it's potentially irritating. You feel it. You're not going to feel water, a drop of water that goes down the wrong way. But a rice particle kind of gets stuck, and you kind of want to clear your throat from it, and so on and so forth. So far more people aspirate than they know. Far more people have reflux than they know, and far more people aspirate a lot, and people have a lot of reflux and they just have no sensation of it. So if you have a condition where it's important to know, the only way you got to know is to test it. Again, that's kind of a common story. So, one of the things you ask somebody, do you cough while you're eating? Actually, I do. Okay, again, as we said before, is it while you're in the middle of the eating process, or you're well into the meal and you're kind of finishing the eating process? So again, is it the swallowing or is it the digestion? And they say, yeah, I cough. Well, yeah, as soon as I sit down at the table, as soon as I start eating, I cough. Well, what food group, or what category of food? Is it more likely with water, or is it more likely with a piece of meat, or is it more likely with whatever? And again, that's how you kind of narrow it down and try to figure out, how you're gonna evaluate that.
What about the idea of, let's say, like we start hearing about silent reflux? So if it's silent, if the patient doesn't even know that they're having these issues, how is that found even? Like,
it's back to the index of suspicion. Silent reflux isn't, it's not silent. It's, I don't have reflux symptoms. Oh, yes, you do. It's your coughing, it's your wheezing, it's your throat clearing, it's your recurrent respiratory infections, it's your sore throat, it's your all that stuff. Those are your reflux symptoms. Mm-hmm. So it's not the heartburn, the agita that people think of as being reflux. So we kind of arbitrarily or maybe not so arbitrarily divide reflux into GERD, gastroesophageal reflux, which is the heartburn, belching, lower down agita symptoms, from the laryngopharyngeal reflux, the LPR, that the EMT people often diagnose, which is the upper airway, that what goes on the top of the esophagus, and that's the one that's often so-called silent. And it's silent not because it's not producing symptoms, it's not producing the symptoms that people are looking for and associate with reflux.
Gotcha. Do we have another question?
Yes. We have a few questions. I'm going to go to this one because it again follows from what you've been talking about. This person wrote in to say, I have COPD. I believe that GERD can be related to COPD somehow. Could you talk about the symptoms of GERD and how to prevent it?
Well, the interaction between GERD and...
I think you're off. I think you're on mute. Yep.
The interaction between GERD and COPD is the chicken and the egg. So many people say that if that reflux may be caused by asthma or COPD because the valve, if you wish, that prevents material from coming back up from the stomach into the esophagus is not a mechanical valve. It's not a gate that opens and closes. It's not a switch that goes on and off. It's the fact that the esophagus crosses through the muscle strands of the diaphragm, and the way the diaphragm is set up so that it pinches it closed and keeps it closed, and relative pressure, and where's the pressure higher and where's the pressure lower. So if you're breathing very hard and you're having more forceful breathing, you may be disrupting that balance. And the people who say that having bad reflux promotes asthma or provokes asthma say no, it's the asthma that's provoking the reflux. And again, it may be all of the above, and it may be kind of a vicious cycle. So certainly going back to the notion of and rather than or, and common things are common. So if everybody has reflux, whatever percentage you like to believe, 20, 30, 40%, are you doing fancy tests to find it? Are you just asking people simple questions to find it? Lots and lots of people have reflux. A very significant double-digit percentage of people have reflux. So, so people with chronic obstructive lung disease are not protected from reflux. There's no reason why they can't have both. So whether there's a direct, cause and effect, or whether if reflux can bother anybody's respiratory tract, there's no reason why it can't bother somebody's respiratory tract that's already been bothered by their cigarette smoking or the fact that they work in a chlorine factory or whatever. I just want to say one other thing, which is a little more broad and touches on some basic research which is being done, and that is how, in fact, does reflux cause respiratory illness and respiratory infections and respiratory inflammation. And people used to think it's the idea, well, if material comes up the esophagus, it kind of jumps over the top and then falls down into the windpipe. And it's not that simple. I mean, most people don't really aspirate such volumes of material, because otherwise they'd have what they call aspiration pneumonia, and they'd really be acutely sick and in the hospital. But there is what we call the concept of the microbiome. And the microbiome has to do with the notion that every part of your body, whether it's your skin or your sinuses or your bowel or your respiratory tract for that matter, has its own native population of bacteria. So the area that most people talk about it is, everybody takes a probiotic now, because if you keep the proper balance of bacteria in your bowel, that it's better for your bowel function, and it's better for your immune system, and it's better for all kinds of things. So that proper balance of bacteria in your bowel, there also has to be a proper balance in your respiratory tract. So if what's in your esophagus and your gastrointestinal tract ends up refluxing, a lot of that material doesn't go directly down into your lung, but it sits in the area around your voice box and changes the inherent microbiome, the flora, the bacteria that are there, probably changes what's going on in your sinuses as well, and that changes the whole population of the neighborhood. And that may be a lot of what's causing this. And this is research that, I know I'm proud to say that I'm part of this at NYU, and, is going on other medical centers as well. And this notion of the unified airway, that don't just look at the microbiome of one of it. When you're doing it, look at the sinuses, look at the voice box, look at the esophagus, look at the windpipe, and and the bronchial tubes, and get everybody involved. Get the GI people, the sinus people, the laryngologists, the pulmonologists, the microbiologists, get everybody involved. When you look at it as one broad system and not as one, with tunnel vision, you're going to get better answers. So again, I went a little bit off to the side, but not really a lot. Someday I'll be able to answer that question better than I can right now.
Super worthwhile, though. Really opening our eyes to things that, I don't think most people think about at all. So we have more questions for Dr. Kamelhar?
Yes, we do. This one goes to a different topic, but you mentioned before something you referred to, I think, as bulbous emphysema? Bullous, thank you. Sorry. Are there different types of emphysema then? And can you say what they are?
The definition of emphysema is an anatomic diagnosis. So asthma is a kind of a physiologic diagnosis, meaning that it has to do with narrowing the bronchial tubes. There's inflammation in the wall of the bronchial tubes, and the bronchial tubes, as a result of that inflammation, tend to be tight, and the muscle spasm, and it's irritable. And when you relax those bronchial tubes, then the asthma will be relieved. But you have to relieve the inflammation. Bronchitis is a concept of mucus. So people with cough and mucus, that's how you define chronic bronchitis. And emphysema is a dysfunction of the lung tissue. So that if you think about your lung as a three-dimensional hairnet, right? So a hairnet, when you take it out of the bag, has strands of elastic, and it has little squares between the elastic. And think of that in 3 dimensions. So you have a nice, young, healthy lung, and you stretch it a little bit, and you let go, and it goes back to its normal size and shape, and you keep on doing it, and keep on doing it, and keep on doing it. And as you get older, right, if you have a hairnet that you wear every day, right, you keep on stretching and stretching, and you just keep on stretching it with your hands. Sooner or later, it's going to become more flabby, and it's going to become bigger, and it's not going to bounce back so well, so it loses elasticity, becomes more flabby. And that's what happens to your lung as you age, right? There's a normal aging process, right? So everybody in the gym, you got 2 guys bench pressing 250, everybody knows who's 18 and everybody knows who's 60. The 60-year-old can whoop the 20-year-old or whatever it is, but everybody knows whose body is which. Everything is looser, your lungs are looser too. So what can happen as part of this process is you start the spaces in between get bigger, and if this happens in accelerated phase, that's what emphysema is, and eventually those threads start to tear. So you have very big spaces, but there's no gas exchange going on because there are no threads there. The threads are where the blood vessels are. So you have a big square in the middle of that hairnet with no threads in it, a lot of air, no supporting structure, and no blood vessels for gas exchange. So that's what emphysema is. Now, sensory lobular emphysema means that sort of little punched out. I mean, again, this is very superficial and kind of visual, but it's kind of little punched out holes here and there. A thread here, a thread there. What they call panacinar emphysema is you start getting bigger spaces, and it's kind of here and there. And bullous emphysema means it's really just a gigantic 2 by 2 inch square of that foot, 1 foot by 1 foot hairnet, that there's really nothing there at all. So it's just a big wide open space. But again, emphysema is as emphysema does. So people hear the E word. They say emphysema. I didn't know I had emphysema. Nobody told me that. If your breathing function is pretty close to normal, that you can have a lot worse asthma or bronchitis than emphysema, and so on and so forth, and it may never progress. So, there's nothing about emphysema that inherently is worse than any of the others. It's a matter of degree. But intuitively, if somebody has big, wide open spaces, that's less likely to be. It's more likely to be disadvantageous. Sometimes those, as they fill with air, can actually start pressing on the healthy lung and causing compromise there as well. So as they get bigger, sometimes one of the things you want to do with your inhalers, with medications, is to allow them to decompress. And you may show no change in your breathing test. There's no improvement in flow, but the amount of air that's in your lung at the end of your breath starts out as 2.5 times what it should be, and that's because those big bubbles of air are pressing on the rest of the lung, and all you're doing is deflating those to 1.5 times, and all of a sudden the person feels a lot better because the healthy lung is functioning better. So, bullous disease can be a little bit tricky sometimes, but again, it doesn't necessarily mean that it's worse, or it doesn't mean that it's worse than anything else.
So can I just follow up on that? I think you said that even though the pulmonary function test doesn't change, the person gets some symptomatic relief, because a lot of times patients come in and we'll say, do you take any inhalers? Do you have any rescue medication? They say, no, because my doctor said it doesn't do anything for me. But we still see, even though it may not change lung function, we do see a significant improvement in, let's say, exercise tolerance or a decrease in shortness of breath.
Well, there are lots of ways. We have very sophisticated breathing equipment, but again, there's always more that you'd like to know. So, for instance, if you have your breathing measured on a relatively simple handheld spirometer, take a deep breath in and blow it all the way out, and that's the whole test. You're not going to measure how much trapped air there is in the lung, or trapped gas there is in the lung. You're not going to measure, how much the lung is hyperinflated, how much bigger it is than it should be. And that's causing dysfunction. And very often you'll find the only difference that you'll measure before and after the bronchodilator is, as I said, that the total amount of air in your lung is twice what it should be. And even with the same flow rates, it becomes 1 1/3 of what it should be. And you're going to feel much better when your functioning lung functions better because it's not being squeezed on. There's a study that they're working on now at Bellevue, different techniques of measuring the smallest of the small airways, the most peripheral bronchial tubes way out at the edge. And they find that very often, let's say in firefighters, a lot of this work was done in World Trade Center, exposed first responders, that these people would have terrible breathlessness and terrible cough, and they did their routine breathing tests, and they found essentially the normal or minimally abnormal. And then when they started using other techniques, which measured what we call small airways, the most peripheral airways, like the smallest branches of a tree, farthest away from the tree trunk, which is your windpipe, and closer to the edge of the lung, like the leaves of a tree, which is really what your lungs are about, where the gas exchange happens. Right, a tree with no leaves is no tree, and lungs without air sacs and gas exchange is no functioning lung. So there, they found that they had a tremendous amount of dysfunction only when they measured using these small airway techniques. And again, similarly, studies are being done in diseases like the mycobacterial infection, which is really an infection of the most peripheral small bronchial tubes. And we find that may be a good way of following it and seeing how people are doing and understanding why people are symptomatic, that even with the most sophisticated standard body box and other formal breathing tests that we do and rely upon, that there may be more to know than we're finding out in a lot of people.
Let's take 2 more questions and then we'll call it an evening.
Okay, this is a question that has to do with pain and rib pain. This person says, I have NTM, bronchiectasis, and Sjogren's disease. For 2 years, I've had moderate to severe rib pain, especially in the lower ribs. Would there be any correlation with diseases?
Well, if you have two questions, this one should take an hour, and the other one may be shorter. So first of all, that's a lot of information there.
I don't have to be at home till tomorrow.
Right.
That's okay.
So first of all, Sjogren's disease is a SJOGRENS, I believe is what you're referring to?
SJ, yes.
Okay. So Sjogren's disease is a disease of the lung. It's what we call a connective tissue disorder, collagen vascular disease. And in the lung, it can cause rounded abnormalities, almost multiple cysts, just all over the place, little small, lots of holes. Again, there's one form of it. There are other forms of Sjogren's, but I don't know what the form that this individual has. So the premise of mycobacterial infection, let's just say this, each one of these is a whole lecture. But the premise of mycobacterial infection is that mycobacteria are organisms that are non-contagious relatives of tuberculosis, right? And they are ubiquitous. They are in all water. Your water, my water, his water, and her water. Everybody's water that flows through a pipe, a reservoir, a stream, a faucet, a bathtub, they all have mycobacteria in it. And that's true in every part of the country, more in some parts of the country than others, and so on and so forth. So if everybody's exposed to the water, and again, there are people who propose that you shouldn't take a shower, and you shouldn't. So the fact remains that a very strong paper written by a fellow from Mayo Clinic named Tim McSamet and a fellow from Tyler, Texas, these really two thought leaders about mycobacteria, they wrote a paper along with another person from Tyler, whom I don't know as well, Dr. Phillips. And their statement at the end of 2013 was, when patients ask us what should we do about water and how should we avoid it, the answer is there aren't enough data to support doing anything about water to tell the patients to change their lifestyle. So other than staying out of hot tubs and using room humidifiers, not taking showers, washing the shower head, a lot of people talk about it. If there aren't enough data for them, there aren't enough data for me. I have to rely on somebody to be smarter than I am. So the premise is, why do people get mycobacterial infection? Because there's something wrong with their bronchial tubes that even though we inhale it and everybody inhales it and we drink it and they drink it and everybody's got reflux, we already finished talking about that. So you have to be what they call a susceptible patient. Right? That's the term that's used. It's about the patient's lung. And there has to be something about the patient's lung that can't repel these germs. And if you have bronchiectasis, we talked about the fact that the bronchial tubes are distorted, they have abnormal size and shape, they don't conduct mucus and air properly, they have abnormal ciliary function, and these are the people, as well as people with Sjogren's, because again, they have holes in their lung, an abnormal lung anatomy, they can't repel it. So this is the perfect storm for somebody to get mycobacterial infection. Now, let's go to the next part of it. So it's Sjogren's, mycobacterial infection, and bronchiectasis. Your lungs have no pain fibers. You could have the biggest, you could have a pneumonia the size of a watermelon. Unless it's touching the edge of the lung, it will not hurt you. You may cough, you may wheeze, you may have blood spitting, you can do all kinds of things. Pain fibers at the edge of the lung, right? Now, so getting back to, so if somebody has bronchiectasis or any of these other processes right up at the edge of the lung, if there's inflammation there, that person may feel like a sticking pain, what we call pleuritic pain at the edge of the lung. So rib pain, I'm not sure how rib pain would fit into those. Is the rib pain part of the connective tissue disorder? And the rib pain is really what we call costochondritis, which is inflammation of the joints between where the ribs and the breastbone meet. That's the cartilage. You can get costochondritis as part of connective tissue disorders. I don't know, again, we're back to the question of, now you need some facts. I need to see the scan, I need to see the rest of the Sjogren's story, I need to see. So, you're giving me a case, I'm presenting a hypothetical scenario of how I can make it fit together, but there's only so far you could take it without having facts. I don't know that I could do too much better than this without
That's great.
without some pictures.
Okay, we have one more.
Yeah, if we could take one more question. This one was just a general question about coughs and what distinguishes a chronic cough. Is it frequency of the cough, or the depth, or the length, or
Well, whenever you get into definitions are always arbitrary. So, the definition of a chronic cough, believe it or not, is only somewhere in the range of 2 to 3 months. It's really not very much. So again, you have to get a sense from talking to somebody of what do you mean by a chronic cough. So in the beginning of the summer, I was with my kids, and all my kids were sick, and I got sick, and they were coughing, and I was coughing, and I took an antibiotic, and I didn't take an antibiotic. Yeah, it's kind of a chronic cough, but I don't know that I would do the same mega workup looking at their GI tract and did you take an antibiotic? You know what, doc, I got to tell you the truth. I never really took the antibiotic. They gave me the antibiotic, I never really took it. So let's stick to things that are simple, like mycoplasma, that kids get and the parents can get, and simple stuff. A chronic cough that's been, well, how long is your chronic cough? 2 years. It's a different story. 1 year, that's a different story, right? And again, my belief is that when somebody has a cough that's been going on for a year or two, number one, you need to have some anatomic, and no matter how much you think you know the answer, no matter how well it fits, that's an up here cough, unless you can knock that cough out in 2 weeks by telling some, and I'm picking an arbitrary number again, 2 weeks, 3 weeks, 10 days, whatever it is, you can have your hypothesis up to here. If your hypothesis this fits the picture of reflux 150%, fine, go for it, right? It doesn't matter if I'm right or wrong as long as I cover my bases. So take the reflux medicine or take the reflux measures. You got 2 weeks. In 2 weeks, if the cough isn't 50% better, 75% better, you're getting a CAT scan, you're getting this, you're getting that, because you just never know. And the patient say, oh, you're looking for cancer when you do a CAT scan? No, I'm looking for that. I'm looking for what's there. Whatever's there is there. All that wheezes is not asthma. If you're a young person, maybe a sarcoid. Another person, maybe a do growth. Maybe it's a benign growth. Maybe it's bronchiectasis. Maybe it's all kinds of things. So, I can be 180 degrees wrong. I can be absolutely wrong. But as long as I put the patient in the protect mode, and I don't tell somebody who has a lung cancer that it's reflux, and believe me, I've seen that too many times, and twice is too many times, once is too many times. Same thing as telling somebody who has chest heaviness that it's your whatever it is, and it was really their heart or their something or other. Once you did the stress test, then you can have your way with it. Then you can work it however you think the right way is to work it. But you always have to protect the patient from something that you don't have as much time with. You've been walking around with this cough for 6 months or a year, and nobody did an X, nobody did a scan, nobody did a chest pain, nobody did a cardiogram, nobody did a stress test. Okay, so I think we need to do it. I think my doctor was wrong, they should have done it, but let's just go forward. It doesn't matter what somebody didn't do. Let's just start from today, and this is what I think you should do, and this is why. That's the long answer to chronic cough. It's a little bit arbitrary, and I think it's somewhere between 2 months and a year, or 2 months and forever. I think that's kind of the way I would answer that question the best.
Last question. How important is exercise for people living with pulmonary disease?
I think that exercise is good for everybody living with pulmonary disease. I think it allows you to do better. I think how you define exercise, how much exercise, when exercise, what type of exercise. I think it's important for making the most of your function. I think it's important for certainly anybody with airways disease to keep airways clear. I think it's important for a sense of well-being. I think it's important to prevent the patient from going down the slippery slope of the less you do, the less you do. Before I had X, I used to exercise, and then I stopped exercising, so not only is my breathing good, but I gained 20 pounds. And I gained 20 pounds, so my back bothers me. And I gained 20 pounds, so now I have reflux, and I gained 20 pounds, so now I snore. And now that I can't really exercise because my back bothers me, so I gained another 20 pounds, and now I'm 40 pounds overweight, and forget about it. I'm just too far gone. So you got to try to always keep somebody doing something as much as they can of some sort. It has to be appropriate to what they can do and do. The fact that somebody is I can't exercise, I got a bad knee. Well, then we'll find some exercise that we can work around your bum knee. And Noah was kind enough to say all the nice things about me, most of which I asked him to say. Not really, but I am appreciative. And that's one of the reasons why I like to have patients come here, because it's not an all or none. How do you expect me to exercise with this fellow? He's got a bad knee, he's got a bad back. I can't do anything with him. You find a way. It's a holistic approach in a wholesome sense of you try to work with everything. You try to work with them to help their knee, help their back, loosen up their whatever it is they need loosened up. And if somebody just can't exercise using their legs, so exercise using your arms, exercise doing something. There's always something that almost anybody can do, and I think that is very important to recognize.
Great. All right, thank you so much. Thank you everybody at home for tuning in. Dr. David Kamelhar. This was certainly educational for me, and I'm sure for everybody else. We went to school today, people. Next webinar is going to be Wednesday, November 19th. Look out for my emails to tell you time, date, topic, speakers, etc., etc. Have a good month, everybody. Thank you very much.
Thank you very much. It was a great pleasure.